Hi everyone, I am Sally Dolton. I am one of 2 paediatric stoma and bowel management CNSs at the Royal London in Whitechapel, and I'm going to talk about supporting parents and children following the ACE procedure. So I've spoken to our adult stoma nurses at the Royal London to see what they would like me to talk about if they were here, which they're not, and they said they'd like some basic information, and the problem that they find most of all when they have transitioned ACE patients is how they troubleshoot basic things, and where they get their supplies from is their main. So I'll try and cover that, but if you've got any questions at any time, do feel free to butt in though. So first of all, what is an ACE stoma? So ACE stands for antegrade, which means the normal direction of flow, continence, which is the ability to retain urinal stool, and enema, which is the introduction of, as you all know, liquid to the bowel to aid evacuation. So basically, an ACE stoma, in whatever form it's made, is the introduction of liquid into some form of stoma here. It flushes the colon out as the patient sits on the toilet. So why do we perform ACE stomas? So primarily to treat fecal incontinence and or constipation. The main patients that we see are previous anorectal malformations, patients that have had Hirschsprung's disease, or trauma patients we see a lot of at the Royal London. And also we find it tends to work best on our patients that have got slow transit colon. At the Royal London, we only perform ACE surgery as when all other options have failed. So we go through all medical treatment, Botox, enemas, transanal irrigation, and after a full discussion with our MDT, that's when we decide to go to ACE surgery. It's something I think about 10 years ago, before TAI, that it was kind of almost first line as patients stepped in the door, but not anymore. So surgery is, unless there's a problem, it's always done laparoscopically. Oh, sorry, my tube hasn't come up there. It's done differently in every centre, so I'm just going to talk about how we do it at the Royal London, and I'll kind of mention how they do it elsewhere. So we use the appendix. So you might hear it called an appendicostomy. So we bring the appendix to the surface of the skin, create an opening, and we teach the patient to intermittently catheterise that stoma. If the patient doesn't have an appendix, we use a Chait tube, which is this little curly one on the right hand side, which is just a trapdoor that, again, we teach the patient to catheterise, and that's how they flush out. But lots, and I think actually probably most centres, use mini or Mickey gastrostomy buttons instead. So at the Royal London, the kind of post-surgical part of it, the patient can expect a 3-day hospital stay. We, in theatre, they put an NG tube into the tract and they stitch it in place for 6 weeks. We teach the patients how to do daily dressings, which they do at home. They come back to us in clinic 6 weeks later, we take the stitches out, we remove the NG tube, and we teach the patient how to intermittently catheterise the stoma. So again, every centre uses different medications for their washouts. At the Royal London, we always start using bisacodyl rectal solution, and we mix it with tap water. I know lots of places just use saline, just use kind of large volumes of saline, and the patient hangs it in a bag and sits on the toilet. We find bisacodyl works better because the patient usually mixes it with kind of 50, 100 mils, whatever. They syringe it in and it works fairly quickly. So rather than sitting on the toilet and waiting an hour or whatever to have it flushed out, it's quicker, which obviously the patients prefer. But lots of the patients do have reaction to bisacodyl, so we tend to move on to glycerin if bisacodyl doesn't work. But all these things are used as well. Clean prep, phosphate enema. We would never use that routinely at the Royal London, but I do have a patient from one London hospital that I won't name that has been told to routinely use phosphate enemas down there. So they are used. So aftercare and kind of ongoing care of ACEs. So once the tube's out and the patient's catheterising, 6 weeks post-op, it's like with the stoma, the patient can go back to doing whatever they normally do. It doesn't restrict them in any way from doing anything. They do washouts. Most of our patients do washouts on alternate days. We do obviously, it's like anything, we do have some that have to do it every day or do it twice a week or whatever, but the majority of our patients have alternate day washouts, and the patients wear a stopper, which is this here in between, which is like a plug, I guess, and they have a little plaster over the top of it to just keep the tract open. So follow up for our ACE patients. So initially when they're discharged, they are discharged home and they're in the care of the children's community team because they have a wound. And after that 6 weeks, but they're equally during that time, we still see them as and when. They can contact us whenever if they're having problems with washouts, etc., etc. They're seen by the consultant and us 6 weeks after in clinic. And then they're followed up routinely or as and when they need in a surgical clinic. They're still in contact with us all this time. If they're ever having problems with washouts, we can, up or down their medications or do whatever we need to do. And then they're transitioned. And so at the Royal London, we have a transition clinic twice a year where we sit with our surgeon, Mr. Cleve, who you'll meet later, and one of our adult colorectal consultants, Professor Knowles, and we all sit in together. Twice a year. We get our patients from the age of 16, and we hope to see them at least twice before they're transitioned. And these patients are also transitioned to our adult stoma nurses. So in some areas, I was speaking to one of the girls from Leeds, I think they're transitioned to the district nurses in that team. But in London, we transition to adult stoma care. So this is where in paediatrics and in adults, I think you guys run into problems too, having to accept patients with ACE stomas. There was a paper written in 2009 about the efficacy of ACEs, and it states that the ACE procedure is not widely known in adult practice, and patients frequently met confusion and ignorance when leaving the paediatric setting, and they'd strongly encourage any surgeon undertaking the procedure to develop links with their adult counterparts. Basically, it talks about the failures of ACE patients, and that potentially these failures are because of the lack of good transition between paediatrics and adults. So what can we do to help patients transition? So there's loads of national guidance and recommendations about. At the Royal London, we've just appointed a couple of CNSs who their job is just to improve our transition care. And our transition clinics, our personal transition colorectal clinics, are working fairly well, but they do still need to be tweaked, I'd say. The problem with ACEs is that there's no official guidance, and because the surgery is not done in adults, you guys, we find, often don't, you may have never even looked after a patient that has an ACE stoma, so it's tricky for us and for you when we have to transition a patient to you that has an ACE. So the way we've done it at the Royal London is we inform our adult stoma care nurses that the patient will be transitioning. So we try and get them to come to the transition clinic as well, or if we're seeing the patient for whatever, like an ad hoc reason, we'll get the adult stoma care team to come and we'll see them together. So we try and see them together, basically, so that they've met them, so that they've seen their stoma, so that they know their routine. The adult stoma care nurse should meet the patient, familiarise themselves with the needs, and the paediatric stoma care nurse should give guidance where necessary. So we still have patients that have transitioned 5 years ago, and our adult teams still contact us about what they should do about X, Y, and Z, and that's, it works for us, particularly as it's such a small cohort of patients that actually do go on to transition with ACEs. So the practical advice for adult stoma care nurses, so supplies. So the supplies, so technically speaking, the supplies, they should be established with the delivery company, as with stoma supplies, and then they just carry on and everyone lives a happy life. However, because a lot of centres use gastrostomy buttons, this is where the problem lies for us, because at the Royal London, in our area, the district team or the GPs refuse to prescribe gastrostomy buttons, and so no one ends up looking after these patients. So I'm not sure how in your own areas you will have to discuss. As I said, I spoke to one of my colleagues in Leeds who says they've kind of have a system where their district nurses look after them, they kind of tell them what to do, they tell them what to order, and it works out fine. So if that works out fine, then that works out fine, but I think it's going to be personal to whatever area you're in and however your paediatric surgeons in that area decide to do their surgery. So for us at the Royal London, because we have appendicostomies and we intermittently catheterise, they'll be established with a delivery company like a stoma care company, and they'll get their catheters and all that jazz from them, and they can carry on their merry way. And hopefully it'll be that easy for you. So stenosis, so they can get, even years after the surgery, obviously they can get stenosis at skin level. We often tell them to just put Vaseline, give it a bit of a massage, or some of their patients, the ACE stopper, like the little plug that they wear, they stop wearing that sometimes after a year or two because the tract's fine and it's patent, it stays open. But if it doesn't, and if it starts getting tight, we just tell them to keep wearing this. They can wear their stopper just overnight, just to keep the tract open. Tell them to wear it overnight for a few hours, take it out, and that should sort that. So feces leaking up from the tube. So we've actually I just had a phone call this morning from a patient that has had gastroenteritis and has had poo leaking out of her ACE stoma. In that case, they can put a stoma bag over the top of their ACE if that does happen. But more often, if they're noticing that they're just getting on their plaster, they're just getting a little bit of discharge or whatever, it's usually because they're backed up. Because they need to increase their washouts or their volumes or their meds or whatever. So skin irritation, the usual things that you do with stoma, we just use barrier spray, or again, it could be because they've got leakage from their ACE. And if their medication's ineffective, which it can be if they've put on weight or lost weight or whatever, you will need to change it, increase the water volume as well sometimes we find. So long-term outcomes of patients with ACEs. At the Royal London, we did a study in 2014 to predict successful outcomes, where we found 78% of our patients achieved social continence after they had an ACE, and 15% eventually went on to have their ACEs closed as they were effectively cured, although there were no predictable outcomes. So when we close an ACE, we literally just let it close up on its own. They can have them surgically closed, but we just let them. So predictors of closure. In 2016, we did another study at the Royal London looking at the predictors for closure. With 85 patients, 35 of those had the ACE closed and 10% of them are failures. The failures are largely due to non-compliance. But also we do have a cohort of patients that an ACE just doesn't work for. The majority of unsuccessful ACEs were age 15 and over and or non-compliant. So we do see, in the reason, chatting with our kind of adult colorectal surgeon, the reason that he doesn't perform ACE surgery in adults is because for some reason that he doesn't know, no one knows, they don't seem to be effective in adults. And he does see that the patients that we transition into adult services often go on to have a colostomy or an ileostomy because they tend to stop working when they get to a certain age. Again, going back to the study that I referenced earlier, whether that's down to anatomy and physiology or it's down to the lack of support, I guess, once they've transitioned is unknown. But of these 85 patients, 60% were treated, as in they were using their ACE and they were continent. 30% were cured and 10% failed. The younger the age at ACE insertion, the higher probability of closure. So we always, when we see a patient initially in clinic and we're thinking about giving them an ACE, we always urge our surgeons to do it sooner rather than later. If we sit on them for 5 years, it's going to be less likely to work. And the younger patients, have better outcomes. As I said, no one knows why at the moment, but they just do. And I think that's it. Has anyone got any questions? Yeah, go for it.
I'm just really interested in this because we've just had a few sort of referrals into us of adults. I think they're coming into adults that have had ACEs, and it's just the management of them.
Yeah.
It's not something I've come across before.
Yeah.
These have both got sort of the gastrostomy tube.
Yeah.
And the issue around that was changing the tube.
Yeah.
So I was just wondering, do you have any guidelines, or do you use?
Yeah, so we actually do have 2 patients I can think of that we have used, because we've done day anyway. We have 2 patients who use gastrostomy, and we've taught them at a very young age to change their own gastrostomies. So by the time they're transitioned, they should be able to change. Yeah, they should be able to change their own.
One of them, I think she does have some learning needs.
Okay.
GP's just been doing hers for years.
Okay.
She was doing it at Manchester.
Yeah.
And then we didn't even know about it. Only that the district nurse was asking about where to order stuff.
Yeah.
And it turns out that the GP just been changing it.
Yeah, just out of the goodness of their heart.
No guidelines or protocols,
No.
so I don't know really where to go about.
And that is the problem. I can see Claire looking back. that is a problem that we find that is a problem as paediatric nurses, because when we do transition our patients, we have nothing, as I said, lots of adult stoma nurses have never even looked after a patient with an ACE. So we'll transition them and say, there's no information, so just kind of crack on and get on with it.
That's what we found,
yes,
like
yeah.
In the surgery centres, the 2.
Yeah.
And we said, have you got any guidelines for looking after it and changing it? And they're like, no. And we're just a bit like,
because the paediatric stoma nurse group, we have been working together for several years, guidelines together. They're written though, aren't they?
They are. So, Gail, throughout Birmingham, they do a lot of ACEs in Birmingham, and they are in the process of developing guidelines on and around ACEs, which do cover balloon gastrostomies in the stoma. The difficulty with supplies is it's the same concept with gastrostomy. So an actual gastrostomy, so a stoma into the stomach with a gastrostomy device in adult world, this is the district nurses that pay for them out of their budget. They're not prescribable by the GP. So it is basically a concept of getting the district nurses to accept that cost. Or it's you as a stoma team, if you have your own budgets, accepting the cost of buying from the company and providing them. So that's the difficulty, because they're not on prescription. But it's the same with the chain device, that's not prescription either.
No.
So you still have to get someone to pay for that as well. And the difference with the chain device is that it's more expensive than the gastrostomy.
Yeah.
So we heavily encourage our surgeons to go down the use of an appendicostomy, because they can be catheterised, and that is available on prescription. But obviously, if the child doesn't have an appendix, you can't catheterise it. It has to have a device in all the time, otherwise it will just pour poo out of it all the time. So we are in the process of developing guidelines with the PSNG, so hopefully they will be out shortly.
I think it was just an issue of getting them printed.
And that's
So they
not
have
charity that's
been
paying
Are you
for printed, it's just getting it done.
I don't think so,
Whether
no.
they will be ready for ASCN or not, I don't know. I'm hoping they will be.
For an insight, I don't know if the programme is out yet. I don't like to say it, but I'm going to say it anyway. That I know that because it's not a secret. That the ACE is on the agenda for ASCN this year, and it's something that they're discussing and working on and having breakout sessions on. So
I think I think just from our transition clinics, it's just with all our patients, it's really important for you guys as well when you're accepting patients, and for us when we're transitioning patients, is to kind of get that stuff sorted before their transition, because
Literally, we've had a phone call, I think, saying, one of them was under the community that we didn't even know about. Obviously their years, GP been managing, and another one is literally, she's coming over to adult. That's it. Like no transition. Nothing. We're not going to see her anymore.
You just have to deal with it.
Yeah, but it's quite scary when you've
absolutely.
It's like troubleshooting if
yes,
went
yes,
wrong,
of course.
Changing a tube that we've never changed before. And the nutritional team, we share an office with them, and they're quite good. But they were like, well, they would normally check pH and everything.
Yeah, I know.
So
yeah.
it's kind of like, well, we've got nothing.
To go on.
Probably in the right place, but how would you know? you know,
Yeah.
stuff like that we're a bit concerned
So
about.
I would definitely say in future, if you accept patients that have gastrostomies, is to say they need to be taught, or their carer or a member of their family, or in whatever capacity, needs to be taught to change that tube before they get transitioned to you. Because also by the age of transition, they should be, you know, if they have no, exactly, if they have no special needs, they should be able to change that themselves anyway by the age of 18. So, and if they can't, they need to have an appointed X, Y, and Z to be able to do it. So I suppose you just need to say we're not accepting them as a patient until, yeah.
Okay, thank you.
Yeah.
Why do you transition to your own adult surgeon? I suppose what I'm getting at, in London you tend to be referral centres, or everywhere tends to be a referral centre.
Yeah.
And so that child is now transitioned to another London hospital when they live in Surrey.
I see what you're saying. So
You know, we don't get any information from that because
Yeah.
they're not being looked after by our surgeons.
Yeah.
But also that they now have to go up to London to be looked after.
Yeah.
They could be looked after locally.
So we actually at the Royal London, we give our patients a choice about whether, also because it depends if those patients are going to university or we actually say to them, do you want to be transitioned here or do you want to be transitioned wherever else? Because we can, it's no skin off our nose where we transition our patients to. So if they don't transition to us, then we will inform the stoma care team at wherever they get transitioned to.
Refer to the colorectal consultant now, though, because that's what our consultant was saying. Is like this, it's pretty much the same as what you're saying. They contact the stoma nurses, but no formal colorectal referral is made to our colorectal consultants.
Okay.
So they're not actually aware of them.
So as far as I know, yes, they are, but I obviously don't follow up every, or the only bit I follow up is that they're transitioned to the appropriate stoma care team.
Different centres do different things. So
Yeah,
down
which
our
is-
down our neck of the woods, our adult colorectal surgeons don't want to know about them. So what happens? They've transitioned back to their GP, and the GP then takes responsibility to look after that patient, unless they then need further surgery or further support, at which point they will be referred to a surgeon at that point. So
But that's where a lot of troubles come because the GP refuses to.
we will refer them to the adult stoma nurses, so that we know
Yeah.
the stoma nurses in the area, because the children's communities nurses in our area don't want to know about ACEs
Yeah.
because they don't see it as a nursing need, and ours team say it's a bowel stoma, so therefore it's under their remit. And so we refer them back, so we discharge them from the paediatric service, so the GP takes them on officially, but we would help sort out resources that they would need prior to discharging them. So it would be sorted before we discharge them.
So can I ask a silly question regarding the channel?
Yeah.
We have a police, but he's 27 now, and when he came first on to us, there was no problems, but the last 4 years, he's had nothing but problems. Does the channel change?
No, it shouldn't. But as I mentioned, we do see that the ACEs do tend to get less effective as the patients get older, and there's no, as far as we know and as far as our surgeons know, we don't know why that is, but it could just be that his ACE is becoming ineffective. So I don't know if you've changed medications or, I'm sure you've done all that. Yeah,
I don't know a lot about them.
yeah, absolutely.
I'm trying to find out the best.
Okay.
So I tried every suggestion everybody gave us.
Yeah.
But it's still
Is it his washout that's not working, or is it that it says washout's not working?
and then the company of the buttons have actually changed the ordering code.
Oh, God.
So we got the wrong button, so it took us, and
Yes,
it
yeah.
procurement in our service. So it was just a
Nightmare.
the last year.
Yeah.
But it's still, the washouts aren't great, so I had said, I would come and ask them to see
Yeah.
what they do.
Well, as I don't know if these guys have got any more. All those, that list of,
And asking, we can pick our brains.
yeah.
We in the paediatric stoma nurse group, and we've got a leaflet, but we're not sharing it because nothing, like I was saying before, nothing is referenced. So although Sally put up some of the solutions that are used, some people will use coffee, some people
Licorice,
will use licorice, make a licorice tea, and so we had pages of it, didn't we? That all concoctions, but it's, you can't publish it, and you can't share it.
Yeah.
None of it is referenced. You know? And then we haven't got any guidance on the, like I was saying earlier about the absorption through the skin. You know, is the absorption of bisacoidal? I know it doesn't, but you're putting it through an organ that is absorbing.
Yeah.
You know, and I know that there was issues with using the enemas, wasn't there? So, but again, you know, some people use salt water. Some people they make up, and so make up saline. And some people use tap water. You know, unfortunately, that's what's making it so hard.
Yeah.
Because there aren't any guidelines, because there aren't any references to it.
Yeah.
And I know that Newcastle did a study once about they were using made-up saline solution.
Yeah.
And they tested them all.
That's Gale does that though, I think, in Birmingham.
Yeah, Gale still
they
makes
do
in
that.
Birmingham, they still make
And they bring in a little pot
Pot.
to clinics and make sure that they're making it up
so they're
correctly.
correct,
Yeah.
concentration of the saline, otherwise that they basically will shoot their U's and E's and they can get really dehydrated.
So
again,
it's a bit slapdash, really. Everyone seems to do things differently, and that it's a bit like that with transition actually. Because if I think of the patients that we've transitioned, they've probably all been transitioned a little bit. You know, depending on where they've been transitioned to, they've all been transitioned a little bit differently, and it's just. Yeah, you kind of have to box and cox these patients a little bit, unfortunately, because there's no official guidance out there about what we should and shouldn't be doing, which isn't very helpful, I know, but we're always here for questions at PSNG if you have any.
Because paediatric nurses, you usually have responsibility for continence as well, and that's where your knowledge is to, and as adult stoma nurses.
Yeah, you don't have it. Yeah. Yeah.
What is the earliest age a child could have an ACE procedure?
So I'm thinking we've done an ACE, I think, on a 3-year-old. We've done a DACE, but we used a gastrostomy button for that. We didn't intermittently catheterize. Are you the same? 3? Yeah. I don't. Yeah. Exactly. Exactly.
They've got to be compliant. So there are some 7-8-year-olds.
Yeah. Who don't?
Do an ACE with, because to sit on the toilet for 45 minutes is beyond their
Yeah.
comprehensions. But so you pick your patients. But I think more and more centres, more and more of us now are pushing towards transanal irrigation.
Yeah, absolutely. Everything else first, basically. And we.
Although there are some centres where the surgeons love doing ACEs and will still go
Yeah.
as a first resort.
We don't do many ACEs at all. I think we've probably done 2 this year, that's all. We don't do many at all now at the Royal London, but we do still do them. So they will still be coming through to adults which is the problem. They'll be coming in dribs and drabs. Yeah.
I think it will be something that will be working its way out.
Yeah, absolutely. I'm sure in 10 years we won't be.
So coming from South, so Mr. Malone, who is the consultant that actually invented the ACE, before he retired, talked about the fact that it's the worst operation ever. And how, to be honest, it was a stopgap. It was something, and he was a great advocate for retired for using transanal irrigations. So coming from Southampton, which is from where he was based, we only do say 2 or 3
Yeah.
stages a year at ACE stages.
But sometimes they do work very, very. Yeah, sometimes they are very good. Yeah.
And you have to have a fairly committed child.
Yeah, absolutely.
Parents.
But the child has to be. So we've got a couple of 2 patients at the moment who, when they were younger, they were very for it. The parents
Yeah.
were desperate for it. They then got to being 11, 12, 13.
But which is again probably part of the reason that they fail when they get to those kind of years.
They want control, so they
Yeah.
they don't do their
Stop it. Yeah.
But reassuringly, you can still have an ACE, but it's not called an ACE if you don't have an appendix, because we have a lot of children that have an ACE and a mitrophanol, so that the urologists fight with the surgeons to who's going to have the appendix.
Oh,
because
yeah.
you need the appendix for the mitrophanol. So a lot of our spina bifida children will have bladder augmentation, a mitrophanol, and an ACE at the same time. So they use part of the small intestine as that channel. It's not as good because it hasn't got the so it's sort of Monty. So it hasn't got the valve in it. So the valve usually goes to the mitrophanol rather than to the ACE. So you can have one if you haven't got an appendix. So if you know a child that's had their appendix out, they still could do it. It's a little bit more fiddly surgery, or you could just put in a button.
Or a chain.
Chain button. So you can still have it even though you haven't got the appendix.
Are there any more questions for Sally?
What ACE stoppers do you use? Because I
I've
had
actually
yesterday with Karen. That was all.
I've actually brought one with me. I'll show it to you.
Okay, let's show and
In a
tell
minute.
break.
Yeah.
Okay, well, thank you very, very much.
No worries at all.
Sally, for dashing over and giving us that overview. Lots of questions, sounds like quite interesting. I'm completely lost, but a very interesting area and one that hopefully there'll be some learnings from your session across to the adult centres. So thank you very much.